In the past, we were used to do mediastinal restaging by mediastinoscopy or even repeat mediastinoscopy, as after induction chemotherapy only. We know that those patients with persisting nodal disease in the mediastinum, so N2 disease, have a poor prognosis. There's now discussion about chemo-immuno as neoadjuvant therapy, whether we should do restaging or not. And as you just heard during the session, most of the oncologists don't think we need to do it, although we are not quite sure, because those patients with persisting nodal disease, I think, will still have a poor prognosis. We don't have the data yet. So in our center, we are used now outside the clinical trial to do mediastinal restaging by mediastinoscopy if we have proven N2 disease by EBUS before the neoadjuvant chemoimmunotherapy. And those patients, most of them will be treated by radiotherapy. So I think it's still useful to do it, although we don't have any definitive data yet. And as you heard, there's a lot of discussion about it. And surgeons sometimes think different from medical oncologists. When we do the restaging by EBUS, so endobronchial ultrasound, or by EUS as a vaginal ultrasound, I think the risk is minimal because it's almost a minimal invasive procedure with puncture. When we do a mediastinoscopy, the risk is higher because patients have to be under general anesthesia. We have to dissect the lymph nodes, which sometimes can be sticky, for example, to the azygos vein, to the pulmonary artery. So bleeding is a concern. On the left side, we have the esophagus, the recurrent laryngeal nerve on the left side. So hoarseness or esophageal tears also possible. And those are very dreadful complications. So we have to teach the younger colleagues and fellows to do a mediastinoscopy in a correct way, because it can provide enough additional information to decide on the further treatment. And also the pathologists like us to do mediastinoscopies because they have larger biopsy samples, so they can do more tests, also NGS, immunohistochemical staining on those biopsies. Mesothelioma is a deadly disease. Unfortunately, I'm living in Antwerp in Belgium, where we have a big port, so a lot of asbestos has been treated over there. So mesothelioma is still a concern in larger ports areas. So years ago, we only had chemotherapy to treat those patients with a rather poor outcome. Now recently, immunotherapy and dual immunotherapy is given to those patients who have unresectable disease. But I have to say that's the majority. Approximately 90% of the patients we see, because diagnosis is usually made late in the treatment of the disease. So 90% are inoperable. For those who are resectable, and nowadays we try to perform an extended pleurectomy decortication to have a maximal debulking of the whole area where the mesothelioma is present. We did with ELCC, a trial of induction versus adjuvant chemotherapy, and all the patients had extended pleurectomy decortications. And what we noticed that after induction chemotherapy, the pathological response is not very pronounced. So most of those patients will still have a lot of persisting disease. So what we're now trying to do is and we'll start a trial in June with induction chemo combined with immunotherapy, which is a tougher treatment, but we hope to have a better pathological downstaging to treat those patients by extended pleurectomy decortication. As thoracic surgeon, I'm especially interested in multimodality therapy of lung cancer and also other thoracic oncologists. Like, for example, the induction neoadjuvant treatment versus perioperative treatment. We still have a lot of questions that remain. When you have given neoadjuvant therapy and the patient has a pathological complete response or a major pathologic response, do we have continued the treatment or not? So a lot of questions are still remaining, and I'm looking forward to an update of several trials that we'll present it over here and to discuss with my colleagues how we should advance. We'll also discuss a newer trial, and all the patients get neoadjuvant immunotherapy with chemotherapy, and after the operation, they are randomized between further immunotherapy or not. And I think that's a very interesting trial to know which patient categories will benefit from further adjuvant treatment after neoadjuvant therapy combined with surgery.